Hi, my name is Patricia Ravitz. I'm a licensed marriage and family therapist, and I am the chair of CAMP's annual conference for this year, 2018. And I am here today with Dr. Adi Jaffe, who is one of our keynote presenters at our conference. And we're here to learn more about his non-traditional approach to treating addiction and to hear some of his ideas on how to make treatment available to all of those who need it. Hi, Dr. Jaffe.
Hi, thank you so much for having me.
Yes, thank you. Thank you for making time to speak with us. I'd like to start by hearing from you what you see as the primary barriers for people to get addiction treatment today.
Certainly. So the question of barriers to treatment entry has been one that I've been interested in since my postdoc work at UCLA, and really one of the first studies outside of the animal work when I was doing behavioral neuroscience research that I did on my own. And what we had done at the time was we interviewed people online who had filled out a survey saying that they were interested in getting treatment, and the help we were providing them at the time was matching them potentially with available treatment. And we asked questions that replicated some early studies from the late 80s and early 90s regarding the barriers to treatment entry. Why are people not actually getting into treatment? And what we found was partially replicating the 90s. So two of the big barriers were cost and shame. And some of the things had changed around that because insurance reimbursement had changed, but shame and cost were two big ones. And then there were other ones that were interesting as well, like logistics. So people had a hard time recognizing where to find treatment that was a good fit for what they needed. They had negative opinions about treatment. And then a question that I was really interested in was this response that more than 50% of my treatment responders or my survey responders answered, which was they enjoyed using or drinking too much to quit, which I call the abstinence barrier. So four primary barriers were shame, cost, logistics, and abstinence. And then another added up one on top of all that was they were having really negative information, negative perception of what treatment is like out there.
Mm-hmm. Yeah, really interesting. So you mentioned abstinence, and I'm curious, since you know, a lot of people, the first thing they think of when they think of addiction treatment is the 12-step program, which is based on abstinence. And so I wanted to get your thoughts about that and how you see that fitting into treatment today.
Yeah, thank you for this question. I would argue that the vast majority of treatment, abstinence is the primary goal, and oftentimes the singular goal that is proposed for people. Obviously, within 12-step world, whether that's 12-step facilitation, 12-step meetings, or treatment that is informed by this 12-step approach, the initial commitment to treatment involves a commitment to lifelong abstinence. And there are caveats to that, you know, you take it one day at a time, etc. But you measure your success by the length of abstinence. And so that is the marker of success and really the only goal that is offered for a lot of people. And I think it makes sense, right? We look at people who are struggling with substances or compulsive behaviors. They can't stop. They engage in ways that hurt their relationships and their job performance and their self-esteem and agency and all those things. And so we want to deliver a very clear and decisive solution. And it seems like the solution should be to abstain. Now, we can argue a lot about the utility of that as a primary goal. But one of the things that I thought of when I was starting to do that research, again, postdoctorally, is if I'm noticing that more than 50% of people are telling me that at least part of the reason they're not entering treatment is because they are not committed to abstaining. They are not ready to stop. They enjoy drinking or using too much to stop. To me, that means that abstinence is an additional barrier to entry. Now, we know cost and shame are barriers, and we try to do what we can about it, right? So we try to get insurance to reimburse better, or we try to bill in ways that that help people outlay some of those costs and parlay them into their payers, you know, the insurance. We try to deal with logistics. We try to make treatment easier to approach and easier to handle. All those things we try to handle, and yet the barrier of abstinence is one that as an industry, we're pretty tied to. And, you know, I work a lot with experts in the harm reduction space, people like Andrew Tatarsky and people like that in New York. We catch a lot of flack for even speaking about the notion that non-abstinence approaches should be a way for people to get into treatment. And so what I want to really remind everybody is we're in this to help people. And it is odd to me whenever we make a decision to say, I'm all in for helping people, but only if they do A, B, C, or D. To me, that puts hurdles and barriers in place that are not necessary.
Thank you. That leads me to want to ask you about the whole idea of recovering versus recovery. And, you know, there are treatment approaches that say if you're an addict, if you're an alcoholic, you're never fully recovered, that you're always recovering one day at a time. And I wonder if you could speak to that.
Wow, what a great question. First of all, let me just right off the bat say that I'm a firm believer that there are people who struggle with addiction issues and they become fully recovered. I just want to be very clear about that. I'm not saying it's true for everybody, but my argument is that the people it's not true for have work left to do. That there will be some people who struggle forever. That is not necessarily a function of the problem they're struggling with, but rather a function of not yet finding a solution for it. Now, that's not true for everybody. I believe in a continuum way of looking at addiction. So there are people on the lower, milder, and moderate end that will have much better success at what I call literally beating addiction, right? Getting to the other side of it and looking at it as a previous phase in their life. I equate it oftentimes to recovery from cancer, for instance. We do talk about people who've recovered from cancer, as in they had cancerous tumors and then either had radiation, surgery, or any other set of chemotherapy, or any other set of treatments to remove the cancer, and then had no return of the cancer for the rest of their lives. The language we use for those people is still that they are, cancer patients in remission, but for all intents and purposes, other than the ongoing checkups, they have beat their cancer, right? It has never returned. It's not an outcome that everybody experiences, but I absolutely believe it's possible. There's another piece that I think is important to explore here, and that is we know, and I talk about this in many of my talks with things like the Pygmalion effect or the expectancy bias or stereotype threat, that the way we look at people greatly influences the actual outcomes and behaviors that they exhibit and experience in the world. And so to me, especially now when we're talking about things like this opiate addiction swell that is primarily affecting younger adults and teens, the notion somehow that just because somebody struggles with drugs and alcohol or compulsive behaviors at one point in their life, that it mandates that they will have ongoing struggles is, it leaves me wanting, because it suggests that nobody gets to overcome these issues regardless of what I call the etiology, right? The process through which their problem developed. I don't believe that all addicts are the same. I don't believe that all addictions are the same. I believe we have to become very comfortable with a much more nuanced approach that allows people to believe that some of them will find themselves completely on the other side of the addiction problem. And it'll be a shorter phase that they had gone through.
In the field today, we're seeing a real directional move toward looking at addiction as being related to childhood trauma. That I think we were much more focused on looking at the substances and thinking that the substance was what was addicting, and now we're looking at the roots of addiction being in trauma. So we have Johann Hari, who has Lost Connections, is on the New York Times bestseller list. We have Dr. Gabor Mate, who's globally renowned for looking at the connection between trauma and addiction. And I wonder if you could share with us your views on this.
Absolutely. So I'm actually in the process of writing a book addressing exactly this question pretty much on the front end of it. And what I think we actually need to do is we need to move away from the search for singular solutions. I think we need to move away from the question of, is it biology? Is it psychology? Is it environment? Is it society? It's all of them. It's always been all of them. And when you actually understand even the biology, trauma and biology are not separate. When people go through specific traumatic experience or attachment experiences early on in life, it changes their biological structure. Literally, it physically changes their brain. It physically changes the hormonal balance and the way their body responds to stress, the level of cortisol they have when they wake up versus when they go to sleep. All these small, nuanced biological processes are completely intertwined with the environmental and psychological reality that people live within. And so I completely agree. It's actually really interesting, right? We've moved from a completely spiritual and moral explanation of addiction back in the day when people would be looked at as literally, beholden to Satan or having demonic sort of forces overtake them and looked at in that way and having very religious overtones to everything. We moved towards a more biological disease approach, which has been the ruling party for, I would say, 30 years. And we're moving to there are a couple of different schools, the more social approach and the more psychological trauma-based kind of approach. And I write about all these in the book. I just really wish that we stopped having this sort of back and forth, pretending that one day we will find that one of these approaches fully explains it. I personally haven't gone through a lot of trauma, and yet I had addiction experience. Why? Because of biological and environmental influences primarily in my life. I think everybody has a different balance. And as a statistician, it's really kind of interesting because it's as if we try to find a singular approach that will explain an entire group, where, as we know, what is much more likely to be happening in reality is the people within the group that we're calling addicts, and I don't love that label, that's why I put in quotation marks, but the people who fit that group have so much variability within them. Which is also, by the way, we talked about barriers before, but it's also one of the reasons why so many people are resistant to the explanations they get from experts. Some experts fully go in on the biological explanations. Others go all in on trauma. Another set of people believe that it's actually a socially constructed problem, that addiction is there because of definitions related to the way other people see your behaviors. All of these are true, and they're true in different balances for different people. So I'm a huge supporter of this move to start incorporating trauma and early life experience and attachment into our conceptualization of addiction. People behave in ways that make sense based on their earlier life experiences. But for instance, Johan Hari's incredibly popular TED Talk now, he ends his talk with, the opposite of addiction is not abstinence, it's connection. That's nice, but it also greatly minimizes the other influences that are present for people and suggests that if we were somehow able to just put our arms around and hug an addict, they would somehow magically recover. So I do want us to respect the differing experiences that people have, while also giving as much room as we can for this new movement around trauma and the psychological experiences of people to really settle in so that we can respect the individual and their experiences as they sit in front of us.
You mentioned 4 barriers to treatment, and I'd like to circle back to that and talk about the ways in which society in general, and then MFTs and other mental health professionals in particular, are potentially exacerbating the problems in access to treatment.
Yeah. I don't think people do this on purpose. I want to preface it by saying that. But I've heard some horror stories from people I've worked with over the time. So to be clear, I'm not a clinical psychologist. I got my PhD in psychology, but then through some of the barriers that I've had myself because of my past experiences that involve criminal justice involvement and things of that nature, I had a lot of hoops to jump through to get licensed and have given that process up. That being said, I've educated, I've talked to people, I've worked as an addiction counselor in my own treatment center, and I've heard some stories that would, in my opinion, completely negate the notion that the field as a whole is helping people. For instance, therapists, psychologists, etc., who tell clients that they won't work with them until they achieve 30 days of abstinence and document their AA attendance. People who force a client into a specific treatment modality and approach because they believe that that's what will work for them, with complete resistance and lack of motivation and acceptance from a client. I think that in our search to help people, we can sometimes become overly dogmatic. Like I mentioned before, I believe abstinence is one of those things, right? When you say to somebody who comes to you and says, look, my life isn't working out the way that it needs to. I'm fighting with my wife. I'm having a hard time performing in work. And yeah, I'm drinking more than I need to on the weekends. And that really rolls into Monday and Tuesday. And it takes me a little while to recover from it. There are practitioners, not everybody, but there are practitioners who go, well, we have to stop the drinking. And that, again, really removes the agency that as a field, we purport to be supportive of, right? People come in for help, and we are supposed to serve as their guides. I have a slide that I might even use in my talk where, I really kind of mentioned we all use this term, right? Meeting the client where they're at. But oftentimes we're not, right? Clobbering the client over their head and dragging them to your side of the street saying, I'm really glad you came for help, but now you need to agree to all these terms for me to actually be your guide and work with you is a little disingenuous. And so my hope, and I've seen some of the other talks over the days of the conference, et cetera, is that people really sit back, absorb, and keep an open mind in terms of what are some new tools, just like the ones we offer our clients, what are some new tools that I can incorporate into the way that I work with people to expand my perception of what is addiction, what is possible for people who are in recovery, and what are the tools that might fit kind of the sort of clients and people that are struggling in ways that are different than the ways that I've conceptualized recovery or the path to it up to now. And really be open to the idea that by opening up your own mind, you can all of a sudden find yourself helping an entire, market, an entire segment of people that you'd never considered were even helpable or were able to take advantage of the kind of services that we offer.
Thank you. I'd like to get your comments on one other kind of surging in popularity tool that we see in psychotherapists' office today, which is EMDR. It seems to be rapidly gaining in popularity, and I'd like to know your thoughts on that tool.
Yeah, so EMDR has been a tool that has absolutely been gaining in popularity over the last 5 to maybe 10 years. When I would first hear about it, it was primarily around the resurgence of early trauma experiences and allowing people to overcome those faster. I was fascinated with it from the beginning. To be fair, I need to do more very kind of deep dive research into the knowledge base around it now. But one of the things that I liked about it from the beginning is it seemed to speak very well to, from the neuroscience point of view, this idea that there are 2 paths in our brain, the kind of the no-go, the inhibitory path, which is the one that's most active most of the time, and the go path. And that by doing EMDR work, you're able to activate the go path and actually reduce people's inhibition around potentially describing, experiencing, and feeling and reliving some traumatic experiences and then allowing them to do the work. Because as we know, one of the things that is so difficult about addressing trauma is the pain that it causes when it comes up, but also the huge inhibitory impulses that we have over it, right? Talking about very actual traumatic experience that brings up a lot of feeling and anxiety, stress, and can actually cause and exacerbate some existing stressors and things of that nature. So I love the idea of EMDR. I personally believe that, we maybe have gotten a little too excited about all the potential benefits that it could have, but I love the notion that there's an additional tool that we can continue doing research with and seeing what populations is it the most useful for, what specific issues, at what points in time, and using which methodologies. And on the end of that, I'll say this. We know the power of the human mind, right? And part of that revolves around the belief that if I engage in a treatment that I believe works, I will gain benefit from it. So if we have people who are struggling with traumatic experiences that they've never been able to discuss, they've never been able to overcome, they've never been able to sort of bridge, their current reality from their earlier traumatic experiences with a therapist or without. And then there's something like EMDR that feels to them like it allows this connection, the gap, the chasm to be bridged. I'm all for it. Because the end result is you get people who have been experiencing trauma, pain, stress, etc., because of these experiences, who can finally connect in a therapeutic environment to somebody who is there to help them overcome whatever it is that they experienced earlier. So I'm not one of those people to look down at the placebo effect. I think it's a powerful and very important, useful tool. At the same time, we should do more continuing research on EMDR and some of these more recent techniques and see where exactly they're useful and for what people.
What do you think MFTs can do to really address the barriers that we've been speaking about, the barriers that are keeping people from gaining access to treatment? What are some of the actions we can take?
I'm a big supporter of having a big toolkit. I'm a really big supporter of looking at what's available out there. You just mentioned EMDR. There are a slew of medications that have been useful for different addictive disorders and things of that nature. Different approaches like harm reduction, moderation, abstinence-based, 12-step and non-12-step approaches. I'm a huge believer in having the biggest toolkit you can. You know, I equate it to a physician, or I equate it to somebody who, you know, a contractor who's building a house. No matter how useful a single tool is, it will never be the answer for every problem you see in front of yourself. And so I know that as a field and as a group, MFTs are highly committed to the improvement and recovery of their clients for their delivery of a better life, greater contentment and happiness in their everyday experiences. To do that, you need multiple tools. And, you know, just like a hammer, which is one of the most useful tools on the face of the earth, can't really help you saw through a piece of wood, or it could. It's just incredibly ineffective and can cause quite a bit of struggle and strife during that process. I urge you to think of all these different tools in the same way. I think we've gone to a place a little bit, especially around addiction. I don't see this quite as much around other mental health disorders, but around addiction in particular. If it worked for me, it must work for other people, is a very, very dangerous path to walk, because we are all different. We know that inherently, and yet somehow we have fallen into this trap where we believe that we will find the singular tool that'll help almost everybody we run across. And so education is the big piece of the puzzle. This is why continuing education and continuing to learn on an ongoing basis, as the field advances, as science advances, as your own experience informs what you do, is hugely important, so that you can keep building that toolkit and be able to offer people what they need.
So in closing, I want to ask you a question about stigma. So that there's a stigma in you know, identifying as an addict and struggling with different substances. There's also a stigma in our culture to seeking mental health care. And we're right between that proverbial rock and a hard place. And I wonder if you could speak to that, that barrier of stigma.
Sure. This is a huge problem on multiple fronts. You mentioned the stigma of having the disorder and the label. I also talk about the shame, which is the internal struggle that somebody experiences when they are stigmatized. And then there's also the shame and stigma related to seeking help, right? So not only are you put down or looked down upon for having a problem, you're looked down at for seeking help. And for a lot of people, that's a difficult road to cross, right? Saying, I'm struggling internally, I will go seek help so that the problems don't get worse. I think there are a few different solutions. First of all, in the addiction space itself, I think we've moved past the days of anonymity. I would really love to see more people in recovery, more people who've been recovered, more people who are in the middle of the struggle being open about what's going on. Because what we end up getting by having anonymity is such a massive force in the recovery portion of this problem, is that the only people we really pay attention to are the people who are actively engaged in the problem behavior. And that exacerbates the stigma around addicts. Because if we don't see a lot of addicts in recovery or addicts who've recovered, all we see are addicts who are actively acting out and engaging in problematic behavior. That creates a very specific sort of image for the alcoholic / addict. So that's one thing. The second thing, and I do this with all the people that I work with, I truly don't understand what it is about our society that has developed this idea that if you get help for what's going on inside your head, there's something wrong with you. And I say it as plainly as this: everything I've learned to do in life, I learned with help. Every single thing. I learned how to walk by having people guide me and show me, how to do it and hold my hands. I learned math, which I'm really good at, but I learned it through listening to teachers and reading books and doing examples from homework, etc. I learned how to read that way. I learned geography that way. I learned history that way. Every single thing, driving my car, I've learned by watching other people, getting help, internalizing it, and then learning how to do it myself, tying my shoes, everything. And yet, somehow, when it comes to what's going on in my brain, we have this ridiculous belief that I have to figure out how to do it on my own, or there's something wrong with me. I wish that we move to a completely different conceptualization of this, and that is the people who care most about having fulfilling, happy, content, gratitude-filled lives are exactly the people who go and seek help when they're not feeling that way. Now, that doesn't mean you have to talk to a professional. If you can have intimate, real, honest conversations about your feelings with your spouse, your friends, your parents, that's wonderful. But asking for help around your emotional well-being should be the standard, not the the standout outlier. Everybody needs help on this front. Nobody lives a conflict-free, stress-free, anxiety-free life. That's a myth that we have somehow propagated, and I hope that becomes our new standard.
Dr. Adi Jaffe, thank you very much for your thoughts, your wisdom, and your time. I really appreciate it. I'm looking forward to your talk on the Sunday morning of our conference and to reading the book that you're writing. It sounds fascinating.
Thank you. Thank you very much. I look forward to sharing with everybody, and I can't wait to see you at the conference.
Thank you.